I'll be giving a quick overview of PCL injuries about repair and reconstruction. So this is not an uncommon scenario that we see in our clinical practice where someone has had major polytrauma. He's had a femoral head fracture, a femoral shaft fracture, that's all been fixed. But for some reason, he's unhappy, and the reason for that is a failure to recognize a PCL tear. So essentially, before I start talking about PCL tears, there are some couple of important points that I'd like to discuss. One is that the femoral footprint is very broad, unlike the ACL. It reaches anteriorly to the roof of the notch. It may reach a variable distance on the posterior articular margin, and this footprint is absolutely flush with the articular margin, which is very, very important when you want to look at placing your tunnels. The fiber tension in the PCL is not a natural distinction, so you don't see two distinct fiber bundles, but you have these fibers that tighten and slacken as the knee moves from full flexion to extension. And if you look at the fiber orientation, you'll find that at full extension, the posterior middle fibers are more taut. As you start moving into flexion, the anterolateral fibers become very taut, and again in very deep flexion, you have the posterior middle fibers which are really taking up a lot of the tension. And of course, the meniscofemoral ligaments are contributory as well. This is a great paper that told us as to how and where the fiber length changes. So it's very important for you to understand that the fiber length change is highly dependent upon whether you place your tunnel, the femoral tunnel, more shallow or more deep. It's okay to err whether you're high or low, which means that if you are deep in the notch and you're not flush to the articular cartilage, there is a higher chance that your fibers will become more slack as you move your knee into flexion. As against, instead of, let us say you want to go to the roof of the notch, but you err by coming down a couple of millimeters, but you're still close and flush to the cartilage, you will not have such similar problems. So remember, more proximal you put your fibers or deep you put your fibers, they will slacken. The more distal or shallow you put your fibers, they will tighten, and that's really very important when you consider the same. The PCL tibial footprint is again a very broad area of insertion. This tibial footprint is going to blend with the periosteum on the posterior aspect. You have the champagne drop-off sign, which is a very useful landmark for you. The champagne drop-off point is right there, where you start seeing fibers of the popliteus. So when you do a single bundle PCL surgery, you aim to reconstruct the AL bundle alone, and it's important that when you're doing a single bundle, you put your tunnel in the AL bundle, not in the center, because if you put it in the center of the femoral footprint, you will violate the anterior meniscofemoral ligament and you will exclude the AL fibers, which are also important. The diagnosis is basically your posterior drawer test, and that's been very nicely described by Grood, and you can have 3 grades depending upon the step-off sign. So make sure that you do a good posterior drawer test, and that is going to be the key to your diagnosis. MR scans are not that great. What is really important is a well-performed stress X-rays. They can either be performed with the patient supine with the knee flexed to 90, or you can get them to kneel down and do the same. And essentially what you're trying to calculate is the displacement of the posterior border of the tibia with respect to the posterior femoral condyle. And when you perform a stress X-ray, you will then be able to understand how much is the displacement. Any displacement which is more than 8 millimeters on side to side is a useful guide that this PCL requires some form of intervention treatment. And again, what we discussed in the previous session, always examine the opposite side. A quick word on repairs. Femoral sided repairs are pretty uncommon. I've treated only about 4 so far up till now, and these essentially are usually a combination of a KD3M when the PCL is peeled off. Here's a femoral peel off with a bony fragment, and the way to tackle them is that they will reduce the knee coming close to extension. As you move into flexion, they will tend to sort of slacken and displace posteriorly. So you need some sort of a controlling stitch to put them in, pull them towards their base. And since this one had a sizable bony chunk fragment, I chose to fix it with 2 screws. On the tibial side, you can use a variety of methods, either the arthroscopic method for very thin comminuted fractures, or if you have a sizable chunk, I prefer to do the mini open through a mini bad approach. So I'm going to discuss PCL injuries on 5 points, whether we should do surgery or not. Let's look at some data. Again, comparing non-operative versus operative treatment. Again, what it shows that if you have significant laxity and displacement on a side to side which is more than 12 millimeters, it's really important that we fix them because they are more likely to unheal. So again, operative or non-operative, there's no strong consensus, but we know very well that about those PCL tears which show more than 8 to 10 millimeters of displacement, they are the ones that require surgery. If you have an isolated grade 1 or a grade 2 PCL tear, maybe with an associated MCL injury, you may choose to treat them non-operatively. The second point is whether to treat them early or delayed. Again, let's look at some data again. A large study which looked at almost about 150 patients with a PCL dominant multiligament knee injury. They divided them into 2 groups, early and delayed. And what you see here in these groups is that when you do them early, you have a much better chance of having less amount of meniscus tears, less cartilage injuries, and less destruction or less problems or pathology in the lateral compartment. So if you do them late, you have a higher chance of having chondral injury as well as meniscal injury as well. What about single bundle as well as double bundle? If you look at the biomechanical data, that tells us that definitely a double bundle will closely mimic all the natural fiber distinctions of a PCL reconstructions, and that is true not only for translation but for rotation as well. Of course, but if you look at clinical data, there's not too much of difference between both the single bundle and the double bundle, and actually the side to side difference of about 2 millimeters is what has been shown when you do a single versus a double bundle. So though the double bundles will show that they are much better, but of course if you look at all the clinical data and if you tease it down, it depends upon which papers you choose to look and pick out. They will show you that probably they are feeling just the same. The difference between a double and a single bundle will be about 1 to 2 millimeters of side to side translation. Whether these 1 to 2 millimeters is clinically significant is what you need to really understand. So no clinical consensus. So my indications of doing a single bundle is when I'm doing a knee dislocation and I'm making several tunnels. I want to minimize my time, minimize my graft sources, and try and do a quick and a good job. When I'm doing a combined PCL MCL, I want to do a single bundle PCL reconstruction. When I'm trying to preserve a lot of remnant, again I'll do a single bundle PCL reconstruction. But when there's a grade 3 PCL PLC, that is the indication where I want to do a double bundle PCL along with a double bundle PLC. The killer turn is what we need to sort out. There's been good literature that suggests that perhaps if you drill from the lateral side, the killer turn can be a lot less. And if you drop your hand lower and try and make a tunnel which is about 60 degrees inclined, you will have a lesser chance of doing a bad killer tunnel. But the more you drop your hand down, the higher is the chance that you will land up in soft bone, which is why what we do believe is your angulation from the plateau of the tibia should be roughly around between 30 to 45 degrees for you to have a optimal control or optimal quality of bone. What about graft tensioning patterns? If you're doing an isolated PCL and you're doing a single bundle, you got to fix it in 70 to 90 degrees of flexion. If you're doing a double bundle, you fix the AL bundle at 90 and you fix the PM bundle almost close to full extension. If you're doing a combined ACL PCL, I think that's really important that you should not tension the posterolateral corner first, but you should first tension the PCL, followed by the ACL and then the PLC. Graft options, you have a variety of autografts and allografts. It's basically dealer's choice. Again, literature not showing too much in change in terms of allograft or autograft, but soft tissue grafts will tend to show more elongation. So if you're using a predominant soft tissue graft, then you probably should be looking at augmenting it with something more. Again, allografts versus allografts, there is no definite change. Last few slides on rehab. Rehab is absolutely critical because we don't know how we should go with rehab. Should we be early and aggressive or delayed and conservative? What's important to understand is that you need to pick the associated injury as well as the graft choice. If you're using a bone-to-bone graft, it's going to heal in 8 weeks. If you're using a soft tissue, it's going to take longer, and an allograft is even going to take longer. Bracing is critical. You need to use a PTS brace for the first 4 weeks, and that's important because if you keep it in a simple straight leg brace, the PCL will still sag. The moment you use a PTS brace, you will see that the whole tibia reduced and your repair is protected, and you need to use some form of a dynamic brace for at least about 4 to 5 months following the same, which will not allow your graft to stretch out. So a minimum of 13 weeks of bracing is important, and it is again graft dependent. Very critical, do not activate the hamstrings for at least 4 weeks after the surgery. That is your key to a good success, and your rehab should always be done with someone who knows how to treat a PCL and by not any other surgeon. So to conclude, diagnosis is critical, non-operative treatment for your grade 1 and your grade 2 PCLs, early surgery within the first 3 months is good, single bundle versus double bundle, similar clinical data, respect the graft tensioning pattern, and rehab and graft choice is critical. Thank you very much.